All right, so trials aside for a moment. So Rich, in the microcosm, single institution, one doc, there are been these performance reviews, and now 3. Have you seen them all? You've seen them for your department? Do you or know they exist? Has there been a formal reporting? Is there a monthly meeting? What's taking place that's bringing the rank and file doc into this process?
Yeah, I mean, so we do have, during our divisional meetings every 6 months or so, kind of an update on how we're doing OCM-wise, and so we do see our own statistics.
So every 6 months there's a meeting. How long is the meeting?
It's a piece of our 1 hour weekly meeting.
It's a piece of your 1 hour weekly meeting. I just wanted to get a sense. This is like when we talk about why we can't make a difference, in healthcare, because the average patient is spending 10 minutes with their doctor once a year. And, what are you going to influence in 10 minutes a year? But I'm just curious for that reason. I'm not picking on you in that way because, you've got the microcosm and Ted, you've got the macrocosm, right? So you're hearing hundreds of practices give you feedback.
I'll give you the numbers.
Yeah.
First performance period, 25% of the practices were what we call in the black. So black and red. Basically, you were either doing better than you should have or basically you were doing worse. 25% were in the black, but then when there was a true up, only 20% were. The second performance period, 33% were in the black, but when they did a true up, only 25% were. Now for the third period reconciliation, the initial reconciliation is 35%, but you would suspect when the more claims come in, it will be a less,
So if you follow that reconciliation trend, our number is improving.
Number's improving, but what that means is that you're dealing with, and this goes back to something that Kavita, you're dealing with basically 30% that are doing well by the measures and 70% aren't. Now, they may have done well in one reconciliation period, not in another, and that's how Kavita was saying.
Because there's very few that are consecutively in the black, isn't that right?
Correct.
That's right.
So which gets to do with a question of a sampling process, right? And
but still, with that many, my point is, with that many that are in the red, even if they've been in the black for one period, it shows you that there are some issues. There are some issues with the program, or there are just a lot of practices that aren't doing well.
Well, it gets into, we have sampling issues, and then we get into it's a moving target. Because the program initial design concept was not related to IT, but a net neutral program in which you're being measured against your peers. So if everything is shifting to the right and everything is improving, in order to stay in the black, you got to do that much better than your peers you're being measured against, correct?
Well, yes, but the problem is, so if you look at a true shared savings program, that's when I'm being measured against you, or I'm being measured against the 4 of you. When you look at a gain sharing program, you're being measured against yourself. The OCM is like a little bit of both, but with a little bit more gain sharing. So I can tell you a practice, I won't mention names, that has been in, 5 different, maybe 6 different commercial models, okay? And has done really well. I can tell you the practice is totally transformed. They haven't done well in the OCM. Why? Because they've already done well. Right. So to do better
they
now,
were early adopters,
when you're measured against
movers,
yourself, it's a real problem. And as Kavita will tell you from a policy standpoint, this is what CMS has learned in terms of with some of the other programs, that after 3 years, you can't keep on measuring against yourself. You have to think about this differently.
But there's also a lag in when the practices get that data, right? So some of why you see this variability in how they've changed is they might have made a change based on that first level of data, but then you don't see that, did it work, right?
Well, you won't see it until you'll skip one. You'll have a skip, right?
That's right. So did you put the right things in place during that, performance measurement time?
Do we have any patient outcome related data? Because the metrics are cost and quality, but we don't have clinical outcomes that we can tie to that yet, do we?
There is a clinical registry that everyone is required to put data into, but we don't have
data hasn't come in.
But we haven't seen that,
So there is clinical data there, which I have to commend CMS for the first time they're trying to do this. Right. But the input, to Ted's point, people have actually hired staff. Columbia's probably one of them. You had to hire people to put that data in, which is, starts to get kind of counterintuitive. So and in the world of electronic health records, we're still in our society not able to extract that information.
And I just want to echo something that Susan said is that part of the problem of the program, and listen, I commend, this is a big undertaking of CMS, CMMI to basically launch something like this, but part of the problem is the feedback is so lags that basically you have no clue. And if you're gonna transform, it's, if I go and I take a course somewhere, basically, and I don't, 6 months later I get my grade, I don't know how I could have done better. And not only that, you want to look at your grade and say, well, did I do well on the quizzes, or I did poorly on the final? How about the oral piece of it? That's what's missing from this program, both in the timeliness of the data and being able to sort of parse it down in terms of what can I be doing differently and better to provide care.
It's not a nimble program. You're not going to make rapid changes because you don't have the rapid feedback. Yeah.
Right.